Hello, my name's Roy Lowry, and this is the Quality Committee of the John Peter Smith Hospital, Tarrant County Hospital District, meeting from September 7th, and we've started at 1:36 p.m. As I call the meeting to order, I'd like to ask if there are citizens that wish to address the committee. There are none?
No.
Okay, good. Moving from there, I'm going to step sideways on the agenda and ask for the folks to come forward regarding the Sepsis Program, please. And I'm going to hand the mic to Mr. Robert Early.
Members of the board, you heard earlier this morning when Dr. Ziegler quite aptly and appropriately mentioned the impact of sepsis and what we've done. The four ladies that stand before you are stellar in all ways. We know what Wanda Peoples can do and what a great chief nurse she is. Mindy Miranda is right next to her. Julie Rogers is in the middle, and Lori Muir. These women right here have accomplished some incredible things for JPS. To back up Dr. Ziegler's comments this morning, to get certified by the Joint Commission as a certified sepsis facility is pretty amazing. And the work that they did and the work that they do on a daily basis is powerful. I will make one anecdotal comment. When the surveyor came in to look at what we were doing, the surveyor, as most surveyors will do, will ask for your policies and your protocols and want to look at those policies and protocols and make sure they're in place. While they were down in the emergency room looking at protocols and procedures, we had a sepsis patient come in and we could demonstrate exactly what we did with sepsis. And at that moment, I think the world changed, and that surveyor said, this is a phenomenal institution. And what you all do and what you can do in the fight against sepsis, where we don't always have all the answers, is pretty amazing. And for those who may be listening, and I not being medical or clinical, but the bacteria that takes place from sepsis and what comes from that wound is a curiosity to us and a frustration, and there are fatalities due to sepsis, and sometimes one doesn't know whether it came in from an external source or is located from within the walls of a healthcare institution. But these ladies and many behind them, Dr. Detienne was here this morning, and unfortunately we had to move this because of time constraints, but it doesn't reduce the meaning and the power of what you all do. So I want to introduce Wanda, who's going to talk in more detail about the superheroes before you.
Thank you, Robert. Like Robert said, a lot of lives are affected by sepsis every year. Approximately 1.2 million patients annually have a diagnosis of sepsis, and more than 258,000 people die every year as a result of sepsis. But the mortality can be reduced by 50% by early intervention, and that's what this amazing team has done. They put together an incredible team. They put together protocols and what we call bundles, which are it's a group of steps and processes that you put in place that you follow every time a patient shows up with sepsis. And as a result of the incredible work that they've done, they've saved over 125 lives, which is amazing, amazing work. And they've saved the organization over $10 million in bill costs by decreasing length of stay in our ICU and general length of stay, and just cost associated with these patients. In 2016, they actually won the Gage Award, which is for an outstanding project from the American Essential Hospital Commission. And then this past year, or this past month, actually, in July 21st of 2017, we had the Joint Commission come in to look at us and to give us accreditation for becoming a sepsis certified hospital. And like Robert said, they were absolutely blown away with our program and what we've accomplished here. So we actually got our official designation on the 31st of August, and I'm proud to say we are the 53rd hospital in the country to receive that designation, and the first and only public hospital in the nation to be designated with sepsis disease-specific certification. So. addition to these three ladies that are here, there's an amazing team around them. Trudy Sanders is their executive sponsor, and then we have a group of physicians and then other professionals throughout the organization. It's definitely a multidisciplinary team, from the ED to physical therapy to pharmacy to, just a multiple host of others that are involved in this project. But these are the three ladies, along with Trudy, that lead this project and have done an amazing job. So please join me again in recognizing them.
Excuse me?
She had a presentation that she was going to, a brief presentation. I don't know if they got it.
Sure, I'm good with it. Go
Okay,
ahead.
load it up for us.
Gave it?
Yeah. And I'd like to, while you're getting ready with that presentation, to thank the hospital district for paying me to be that patient that showed up that day, making believe I had sepsis. Those of you on the internet, please, this is my sense of humor, I'm sorry. The outstanding occurrence and timing that we got to look so good so quickly to the evaluators, that's remarkable.
And let me just give you some background is that, put it in layman's terms, why do people die from sepsis? It's actually not the infection, it's the body's reaction to the infection. We recognized that over 100 years ago. That's the body's reaction. What happens is you get this inflammatory reaction, and what happens is body parts that weren't involved in the infection start getting inflamed and start failing. So you get lung failure, liver failure, kidney failure, brain failure. And by acting on, when someone's got a severe infection, by acting early, you can alter outcome. We know this where it kind of follows with trauma. In trauma, we have what's called the golden hour. A patient comes in, we've got to act right away. Someone comes in with a heart attack. We know that if we get that patient to the cath lab in a timely fashion, we can save lives. Now we're working with strokes. We're now a stroke center. That if you have a stroke, we've got a protocol that we're going to get treatment started right away, and by doing so, we can save lives. We've been doing this for sepsis for a long time. And I really want to thank Laura Muir. She's the one that really got us off the ground. And by looking at what we were doing each month and where we were doing good and where we weren't doing so good. And long before there was any recognition for that, she was really the one that helped us get this going. And do they have the presentation?
They were putting it on the screen.
Okay. So, and I do want to thank the administration for being they were the ones that were helpful in supporting this. And so it's been something we've been actually doing for a long time. And mortality when I first was here was probably close to 40%. And now it's down to about 10%, again, because we do things in a timely fashion. And I'm glad there's now recognition by various organizations.
And the slide presentation is pending. We're working on it. If you could tell us how to imagine each slide, we could imagine if you will.
So, my name's Julie Rogers. I'm one of the
Thanks, Julie.
clinical sepsis nurses that work here and have the joy of being on this team. And I just wanted to talk to you guys briefly about the Sepsis Program and the sepsis certification project. Pretty much we wanted to just discuss what is sepsis. Sepsis is an immune response that happens to the body that can end in end organ dysfunction, and if left untreated can end up causing death. We have actually seen a huge progression with our practice with this, and over the last several years we've actually moved forward. Initially, 5 years ago, as Dr. Ziegler was saying, Laura Muir went ahead and started with Dr. Ultraman and starting the Code Sepsis program. And with that, we've made great strides. With using the 3-hour bundle, we're able to decrease mortality by over 50%. Our ER docs are instrumental in activating Code Sepsis over 92% of the time, and we're doing great with all of the bundles. I'm trying to think what else I was going to say. Our big thing was being able to be Joint Commission certified is just amazing. We have had great support with our physicians, and that's been instrumental in it. Our ER docs, our ICU docs are always very prompt and responsive with this, and that's made it, the whole process be so successful. So thank you very much for your time and your support.
Thank you, and congratulations on doing a presentation when your slides failed.
Thank you.
So it is true, Dr. Weber says we weren't all that bad a few years back, but medicine has come a long way from the days, those of you who know the history of Doctors Semmelweis and Lister, and people just washing their hands between the morgue and the operating rooms, which was unheard of just a couple, 300 years back. So anyway, that's the end of my history lecture. We slipped past the approval of minutes. The minutes are available to you if someone has had a chance to look at them and or would offer action. Motion made by Dr. Weber, second by Mr. Powell. All in favor? Aye. Opposed, same sign. There being none, it carries. We have the approval of Tarrant County Hospital District policies on 2 items. So we'll do one at a time. We all have those in our packets. Thank you. Okay. So item number 1, the approval of policy, and I read this morning. Approval of the policy on brain death. Discussion before we have a motion. Recommend approval. Recommended by Dr. Weber. Second.
I second.
Dorothy, I'm sorry. All right, all in favor of approving the policy for brain death, say aye. Aye. Opposed, same sign. There is none, it carries. Policy number 2 for handling and movement, pages 6 and 7 of your presentation. Discussion, motion. Thank you. Secretary Schrader, second. Ms. Dorothy DeBose. All in favor say aye. Aye. Opposed, same sign. There being none, it carries. Performance improvement updates. I think that's where we are. Mona? Yes, your name is first, ma'am. We're delighted to welcome you today. Anything you want to tell us?
Good
Yes.
afternoon, Mr. Chairman. I am going to present with our Chief Nursing Officer, Wanda Peebles.
Very good.
So good afternoon, everyone. My name's Mona. I'm the Executive Director of Quality. And today we are going to present to you our quality outcomes update. The last update that we presented was in March of this year. So our quality outcomes update is our opportunity to show you progress on our destination metric, which says create a safe environment of care. Create a safe environment of care for JPS patients as benchmarked and reflected on the Leapfrog Hospital Safety Grade. Leapfrog validates our organizational efforts to improve safety, culture, and efficiency of care. Our 2018 goal is a grade of a B, and our 2020 goal is a grade of an A. We started this afternoon's meeting with the recognition of our sepsis team, and being the only public hospital in the country to have sepsis certification through the Joint Commission only validates our commitment to the safety of our patients, not only for the residents of Tarrant County, but all the other patients that would use our services. We look at this destination metric, and we are also reminded that it supports several of our organizational pillars, not only under quality, but also for service, for stewardship, and for people. Wanda is going to help me with the action plan updates because a lot of the action planning and implementation is done by our clinical staff, and this is in partnership with the rest of the clinical staff, which is led by our physicians. So let's talk about catheter-associated urinary tract infections, CAUTI. I put a star there. This is an updated version of the PowerPoint slide so that it will be easier for you to track. We start the fiscal year with October 2016, and so far we have had a total of 5 publicly reported cases.
That's the beginning of the fiscal year.
Sir.
It's not on mine either.
Predicted measure form.
That's why it's on the screen, yes, because we don't know.
I wanted to make sure that it was easier.
Okay. The action plan that we have around having these 5 urinary tract infections is that we actually have a multidisciplinary Clabsi team. It's a group of physicians, nurses, pharmacists, and different clinicians who come together pretty frequently to look at our processes and develop and put together protocols to prevent these type of things from happening. Anytime that we have a chronic Clabsi, this group is called together and we do a full root cause. Sorry, my battery died.
Well, it's a budget saving term.
Got it. Anytime that we have a CAUTI or a Clabsi, we pull this team together and they do a really deep dive and a root cause analysis to determine what actually contributed to that infection. We have put together quality nurses now that we have on all the PCUs, the ICU, and now we have expanded those nurses to the med-surg division because we're starting to see CAUTIs pop up outside of in the ICU or the other areas because we are getting sicker and sicker patients throughout the organization. So these nurses actually report to nursing. They don't report to quality. But they are on the floors, and that's what they do every day is just drive the quality and follow these patients with these lines, with all of our quality indicators like pressure ulcers, restraints, all of those things. So it's a real intense focus on that.
Okay, Wanda, excuse me. I have a technical question now that I will let myself think about this a little bit. In both cases, catheter and central line things, the technical side of this is it's only someone with one still indwelling, whether it's a catheter or central line, or they've had one and it's even discontinued. Do they still fall under the criteria if the catheter's been discontinued a day or two, or is only for indwellings? And the same with central lines. I'm asking, I don't know. Do y'all know?
So there is a criteria, sir. So all our CAUTI events, CAUTI, Clabsi, surgical site infections, we report all events that happen in the organization to the Center for Disease Control, National Healthcare, NHSN, Safety Network, NHSN. And when we report it to NHSN, we have to make sure that we meet certain criteria. One of those criteria is temperature. So there is a certain threshold for fever. The number escapes me at the time, but they have to have spike temperature. They have to meet certain number of organisms. There is a threshold again. It's about 100,000 CFU units. For a certain bacteria. And then the catheter should have been in place for more than 2 days, and there is another inclusion criteria based on the number of days. Another example too is if we had a patient that came in with a catheter and that... Oh, sorry.
You're good, it's just a favor call.
Mr. Early, I am just following up on an action plan from the last meeting when you couldn't hear me, so. Thank you, sir. Yes, sorry. And I get very excited also when it's about these things. Thank you. So there are certain criteria. An example would be if we had a patient that came into us with a catheter, or even if that person was admitted to us without a catheter and the person developed fever in the 48 hours that that patient is here, then that is considered a transfer rule. So based on NHSN, that is not an event that should be put on JPS list. So we will not be penalized because there are certain criteria that we do follow. One of the things things that our infection control department has done, and also our, in collaboration with our nursing leaders and quality nurses, is to make sure that every quality nurse, in fact, every nurse understands what those criteria are. So our nurses are educated, and also with our physician partners, we want to make sure that they understand what those inclusion and exclusion criteria are.
Okay, I'm not sure if I got the exact answer to what I asked, but the
Yeah.
rest of the question is,
Yeah.
so you have a patient, their catheter has been out 2 days,
Yeah.
but they seem to,
Yeah.
no catheter in place, they can still fall in that group?
Yes, sir. So
Okay.
if they meet the fever criteria, they meet the 100,000 CFU, and
They had any time during the
if
hospital
they meet
admission?
those two, it will be considered a catheter-associated urinary tract infection.
In a certain time frame.
Yes.
It's both.
I'm sorry, I won't ask any more questions. Go ahead, please. Go ahead. Yes, ma'am.
With these 5 that have happened in the last couple of months, were these cases from outpatient that came in? Were they in-house? Or were they misdiagnosed?
They're all inpatients. Yes, yes,
Okay, so did they all qualify for?
Correct.
yes.
We're doing such a, this staff is looking for every opportunity to not have catheters in. I was up on the floor the other day and saw something they were doing that was kind of, I thought was unique, to really make sure that they're not putting them in. They're actually using, for females, external pads that will soak up the urine, and if the patient's on I&O, they're actually weighing the pads, just like you would a baby, to determine I&O, which I thought was pretty ingenious. They're looking at every opportunity they can to not have a catheter in those patients, so.
Okay.
And then we're doing extensive education with the nursing staff to make sure that we're looking at the daily care and the maintenance, and making sure that we maintain a closed system for all those patients.
Great. So for Clabsi, central line associated bloodstream infection,
He had a question.
again,
Dr. Ziegler.
oh, sorry, sir.
A comment, there was recently, so I've seen some editorials in some of the journals. I mean, you do have to use urinary tract catheters. I mean, it's an essential part of certain patients' care. One of the things that they were commenting on is you have to consider patient comfort. So for some patients, it's just very uncomfortable to have to sit in the bedside commode or get on a bedpan, and we have to consider the patient. And what the thinking was that these were mandates that were put out by the federal government, taking everybody in consideration and not looking at subsets of patients. And so there are some times when we have to really consider the patient. But saying that, again, whenever we have one, we do critical care committee. We went over all the different ones that we have. I mean, we have to look at each one and see, was there, I think maybe we have to do a better job is documenting why we're having to leave the catheter in. I certainly trying to do that now every day in my daily note. If they have a catheter in the ICU, I've got to document why I have that in. So I think you might see some literature where people are starting to say, well, wait a minute, that was good for everybody. Yeah, we certainly left catheters in way too long, and so patients got urinary tract infections, and we've got to do a better job. But there are times when you really do need it. And there are times when I just got to know how much urine a patient's making. I really have to know that, especially in the ICU. And so I may have to leave catheters in a little longer than the federal mandates. But again, I think if we're documenting that, maybe that'll be one of the exclusions that we can look at or have, so that we don't get caught with all the cauties.
Okay.
I have a question, and thank you for that insight and can that be separated if they get a urinary tract infection, if they're in the ICU, when it's mandatory and very well needed that they need to know the levels of urine?
I know the federal government is looking at it, and there'll be some more exclusions hopefully coming down the pipeline. But because, it's still an essential part of patients' care. And where I think the criticism has been, it's patient comfort, and you really have to consider that. Well, if you leave them in longer, you're gonna have more infections. Yeah, you might. But again, we have to consider each patient.
But it's the care that's more important, right?
Well,
Their
that's the
comfort.
concern, is that you have people looking at one specific thing. Now, all we worry about is the infection. We don't really care about the patient. And we as the physicians and the medical staff and all the medical personnel, we got to step back sometimes. Is this really in the patient's best interest? I mean, this patient's not really. It's going to cause them a lot of comfort to take out the Foley and have them sit on a bedpan, and we really do have to consider that.
In relation to that, Ms. Early, what has happened also in relation to patient comfort is some manufacturers actually now have developed what we call female urinals. So because of the reason that Dr. Ziegler just mentioned, they're talking about patient comfort. So that's one thing that we're so used to just seeing male urinals, but today we have what we call female urinals that actually will help prevent starting a Foley. One of the best ways that we can prevent infections is to make sure that we don't start a Foley catheter. However, in the critical care units, it's almost so dependent to the care of the critically ill patients. Our nurses here actually have done a great job of making sure that the insertion is done under sterile precautions, and also making sure that our daily maintenance, we're making sure that we're cleaning the areas on a daily basis, and making sure that we are always thinking about that patient, and making sure that we're doing our best to take care of that Foley catheter.
I understand the discomfort in that. Does JPS have the female urinals?
I think we have a couple, yes.
We're trying
Yes, yes.
More than a couple, probably.
Well, we're trialing it right now, so.
I have one more question. I look at this chart, and thank you for the charts. I mean, it just shows the progression, but not in this case, unfortunately. So I see that, from 2016 to 2017, that we did really well. And then my question is, what happened to that piece of the puzzle that it failed?
And the reason we had 3 in 1 month, we kind of had the perfect storm. We had some very sick patients, for one thing. One of the patients had multiple pelvic abscesses, scrotal abscesses, bladder injuries. There was a lot of things going on with that particular patient. HIV, it was just kind of, so really prone to infection. Another one was a very combative stroke patient. During insertion, they think there was possibly some contamination during that process. And then the last one, I think, was just another very, very ill patient, so.
Yes, thank you for that insight again, because, sometimes it's like, these numbers are like, you have very good reasons why it happened, but it's still gonna go against JPS.
When you look at the numbers, even though we had 3 this month, and you compare, we're going to pass out something now that will give you a little bit of perspective. Even though we've had 5 this year, when you compare us, NHSN predicts how many you're going to have in a year based on your patient population and your volume. They really predicted we should have had 13.4 this year based on that, and we've only had during that time frame 5. So that kind of gives you a little, we're doing extremely, extremely well based on our peers and the rest of the country. So even though we have had a few, we probably should have had them
Well, and
twice.
if there's a flaw with the value-based medicine thing is, we can all agree that the ideal is 0 all the time. And if somebody shows me a report from my year's experience in medicine that has 0 all the times for things as common as urinary tract infections with catheter patients, I'm going to have a problem with their truth-telling, because these are areas that can get infected and contaminated. I think given the immunocompromised patients that we see here all the time, and I mean something as simple as diabetes, some of the regular diseases that make one prone to infection, our numbers are outstanding. They really are. So, and thanks for the other update. That's a handy piece of information.
That shows the JPS rates, and then the predicted rate is the third column over of how many we would be predicted to have based on the national standards.
So this is for the calendar year 2016, and this comes from CMS. You've probably heard of Hospital Compare. It's a website that consumers can actually access if they're trying to think of a hospital and they have a procedure coming up. They can actually compare hospitals and look at certain indicators, and this would be the indicators for hospital-acquired infections. So last year for 2016, our catheter-associated urinary tract infections was at 5. Our predicted number for our type of patient population and our size is about 13.480. So way, way below than what was predicted by CDC and HSN for JPS.
Okay. That's a very good update. Are we ready, without other questions, proceed to Clabsi?
Yes, sir. So for central line associated bloodstream infection,
I'm gonna come back to this.
we're currently at 5. And I believe that the action plan is similar to our central line, to our COTI events, unless there is additional items from WANDA.
Now, we have the same multidisciplinary team that looks at all of these. They run a daily report, track these patients daily to make sure that we're getting these lines out appropriately, that care is being done appropriately. As a matter of fact, Bill and I was rounding on the floor the other day, and the quality nurse was on the floor, and she looked really sad, and wasn't her bubbly self, and so I went up to her, I was like, ask her what was wrong, and she was, you could tell, visibly shaken because she thought we had a Clabsi. And so that's how seriously they take it and track it every day. And so, again, if you look at our actual rate to our predicted rate, we're doing extremely well.
Okay. Everybody good with the Clabsi data? Surgical site infections,
So
colon
first,
procedure.
yes, sir. So for surgical site infections, colon procedures, if you will look at October 2016, where the star is, we had 2 events, and then November 2 events, December 4 events, January 5 events, and then February 3 events, and then from March to May, we have 2 events per month, for a total of 22 events.
Okay, now, if I'm looking at your little report, that one would say that for our hospital, we should have 7.8?
Yeah.
Oh, okay.
We're way above the predicted number for our hospital.
Oh, okay, all right.
So the rest of my understanding as chairman of the quality committee is we state goals for ourselves, and one of our goals would be easily stated, unless somebody disagrees, that we would like to see that number drop significantly.
Yes, sir.
With the other thing that I'm just a poor, uneducated ENT surgeon, but the colon happens to be one of the dirtiest areas to operate in the body. So the numbers are going to be considered higher for that reason, I would assume, unless my general surgery colleagues disagree.
Well, hopefully they will, since we are a safety net hospital, I have seen some things where the agencies are going to try to weight it. If you have a facility that takes care of a lot of patients that have bad diabetes, liver disease, malnutrition, you're just going to have higher infection rates. And hopefully they'll will allow for that. But we do need to do a better job. We have enacted several things. We're changing your gown when you're closing the skin, better techniques for closing the skin, making sure they get their preoperative antibiotics. There's a whole bundle of things to be done that we've initiated and will continue to do so.
So we do have a multidisciplinary Zero SSI team that is led by Dr. Dwayne, our vice chair for quality for surgery. And one of the things that multidisciplinary group has done is to work on an SSI protocol implementation, which is really about optimizing the patients. So even before they come for surgery, we want to make sure that we're doing pre-operative education with them. So we talk to them about their diabetes, we talk to them about maintaining their blood sugars, ensuring that we are talking to them before the surgery. And what the team has also put in place includes pre-op baiting using a special cleansing ingredient, HebeCleanse, we call it. We used to, when we had the spike, we were only asking our patients to use HebeCleanse twice pre-surgery. Today, we're asking them to do it 3 times pre-surgery. And today, we're also using chlorhexidine wipes on our patients' hands pre-operatively. And so before they enter the surgery area, they have done their HebeCleanse, and we also do another step on making sure that they are really, their hands are clean, and then their surgical site is again cleaned with chlorhexidine. We also apply nasal iodine on their nose to help prevent them breathing on their surgical site or creating a site for infection. We also now have instituted pre-warming our patients before they go to surgery. What the evidence has shown is that when in the ORs, it's really, really cold, and that is not helpful in maintaining, it puts our patients more at risk for infections. So what we have done is, before the patients go inside the operating room, we actually pre-warm them using a warming blanket. And then we also make sure that their antibiotics are the right antibiotics. We have an antibiotic stewardship program here at JPS, and we actually make sure that the timing is appropriate, because even if we are giving the right antibiotics, if it's not given in the right timing, it's not going to do any good for the patient. And then antibiotic redosing is provided if the surgery or the patient loses more blood. And then just concerted effort, making sure that we are following this bundle to take care of our patients.
Or do you use that just during surgery?
Immediately before the surgery. There is a specific timing for that, and our anesthesia practitioners and our surgeons always want to make sure that that is given within the right span of time.
Okay. So we've set a goal, and shall we move to abdominal hysterectomy?
So for abdominal hysterectomy, in May of this year, through the direction of the Strategic Operations Council, which is led by Mr. Whitman and Marianne Roth, we called the chair for OBGYN to make sure that she is able to come to the group and provide an action plan on how we can reduce or eliminate surgical site infections for abdominal hysterectomy. We're currently at 16.
We need to change.
Oh, sorry. We're currently at 16 total until May of 2017. And what we have done is one of our managers for OB, Jerry Ames, and Dr. Simonian, one of our OB medical staff members, actually joined together and convened a group. And this group actually includes some of the committee members for the surgical site infection colon group. So we're now sharing what we have learned from the colon group with our abdominal hysterectomy group. We just started with looking at our process, mapping the process, and understanding what are the things that we can do differently to make sure that we are meeting the needs of this specific patient population. One of the common action items that we have done, or the group has done, is, again, optimizing the health of the patient prior to the surgery, controlling blood sugars, ABA1C, pre-warming the patient prior to the surgery, and of course, antibiotic stewardship.
Okay, other questions on hysterectomy? Okay, let's move on to C. difficile.
So for C. diff, inpatient healthcare facility onset, so this is healthcare acquired C. diff. And we are currently at 68. For our action plan, we again have a multidisciplinary group that looks at this through our infection control. We also have surveillance, isolation precautions using our personal protective equipment, and then cleaning of patient rooms. One of the most important things that we can do as an organization to help with C. diff is proper hand hygiene. Hand hygiene is so important and is so foundational to everything that is caused as a healthcare acquired infection. So not only on us as healthcare workers, but also on patients, visitors, family members, we want to make sure that we are adhering to hand hygiene techniques.
One thing that we are trialing right now is the new UV light process. It's a light that you can put in the room after the room has been cleaned that supposedly kills all these organisms. So we're trialing that here as well. Not for it to be the end-all be-all, but to be in addition to our regular cleaning processes.
Well, and all of these patients, we have one more infectious thing to deal with yet, but all these patients are not living in a pristine, sterile environment. They're in their hospital room with guests coming and everything else. C. diff is very prominent in nursing homes, and if you're seeing a large number of the elderly, it is out there amongst them anyway. So these are difficult sites. Again, we all agree the ideal is 0. If we can get to smaller numbers, I think that's a great accomplishment. Any other comments on C. diff? Questions? We'll move to MRSA.
So for our methicillin-resistant Staphylococcus aureus, or MRSA, we're actually doing better than with C. diff. We're currently at 4, and we hope to continue keeping the 0 occurrences. And we have the same action planning for C. diff and MRSA.
Okay. Very good. Moving from infectious disease to hospital-acquired pressure injuries.
For our hospital-acquired pressure injuries, we're looking at a score greater or equal to 3, and currently we have 2 events. And Wanda, I think, would like to share with us a great accomplishment for nursing.
Yes, we have a multidisciplinary team that looks at this as well for our pressure injuries. And one of the things that we have in place in the ICU is we use, and I think I've talked to y'all about this before, the LEAF process, which it's a disc that they put on patients that you can tell, it hooks to the computer, your degree of turning, so that we make sure that we're turning patients appropriately. And we just got our results back, and we are currently in our ICU at 97%, which is the highest in the country, and we have been since we implemented this process. And that's over large institutions like Stanford and some of the really big hospitals that are out there. Our staff has really embraced this, and the company can't believe how well we actually are doing with this process of making sure that we're turning our patients appropriately. We also have implemented a skincare bundle like we have with Caudy and Clabsi, so that we make sure we're taking care of our patients' skin appropriately. The 2 that we've had this year, one was due to a very, very sick patient that had a very low albumin and ended up with a pressure injury. And the other one was just another extremely ill patient. And looking back at what we did everything appropriately, and just due to the patient's overall condition, they developed a pressure injury. But we, based on our predicted score and where we are here, we've done extremely well.
Okay. Good number. Other questions? We'll move on to falls with injury.
So for falls with injury greater or equal to score of 4, we have 1 event, and that was in January. We do have a multidisciplinary 0 falls team that looks at every fall that happens in the organization, And then because of this fall that happened, the towers put in place a standardized face-to-face handoff between unit staff and transport staff. So we wanted to make sure that we were communicating with the staff on the floors that we are returning a patient from a procedure. And then improve Tower 11 process to ensure high-risk patients located close to the nursing station so that we can make sure that we're monitoring those high-risk patients more often.
So
So-
what happened? I'm going. I'm sorry.
500 beds times 365 days and one fall.
Well, it's not
Shame
just-
on you. That's,
So this is a fall with a
Really
score
low.
of 4.
Congratulations.
Yes, yes, yes.
that's congratulations, absolutely. Okay.
And
To quote the book, The House of God, Gomers Go to Ground, go home and read if you wish. The House of God is a good book. Okay, falls with injury, we're done. Destination,
So again, we are, JPS as an organization is on a journey to excellence, and we will do this through high reliability organizing. We cannot stress the importance of preoccupation with failure. When you, Mr. Chairman, and the Board of Managers Quality has set SSI as our goal, for the coming months, we want to make sure that that failure will allow us to learn from what are the things that we're doing well and what are the things that we should be doing differently. And sensitivity to operations is making sure that we're respecting our frontline staff, because those are the people who understand the day-to-day happenings at the frontline level. We listen to them. When our senior executive team does their executive rounds, they're really listening to that voice of the frontline staff and wanting to make sure that we bring that to the proper forum so that we can discuss it further. When we say we are reluctant to simplify, healthcare is a very complex and complicated organization, so we cannot simplify the things that we're doing. However, what we can do is we can learn from this complexity and find out what would be the processes that can help us be more effective. Commitment to resilience. Yes, our SSI numbers are high, but we also know that we have done it with COTI, Clabsi, and we know that if we can transfer those processes, those best practices to SSI, we know that we can bounce back and we can take better care of those patients. And then, of course, deference to expertise. The clinical staff, our physicians, our nurses, our ancillary team members, our EVS members, they are the experts in the areas that they're working on. So we defer to that expertise, and we will continue to listen, and we will continue to learn from one another. So thank you so much for your commitment to quality and patient safety, and thank you for supporting us in our efforts towards our journey to excellence.
thank you, Mona, you have great passion for your work. And it makes it easier being chairman of quality with somebody with that passion. Dorothy?
I would like to ask that we get a little bit more information on looking at leapfrog, how this report ties into that, because that's major and that's quite serious. And so you pass this out, but I don't think, as I'm going through here, I understand some of the information. So I would like for us to have, maybe not today, but sometime where there is more of an explanation on how this tie into leapfrog. And when we're out there looking at comparing our hospitals to other hospitals, what those numbers mean and how we actually do look at it.
So we can think about doing that again next time.
Yes, sir.
Fair enough?
All right.
Okay, other questions or comments? Yes, ma'am? Well, Rex, excuse me.
Where does antibiotic-resistant bacteria and things like that fit into this, these statistics?
That would be with MRSA, sir? Yes. And, yes, sir. So we have an antibiotic stewardship program that is led by Dr. Teshe and Dr. James Sanders with pharmacy. And we have a multidisciplinary group that looks at that.
So that's the MRSA bacteria?
Yes.
I'm sorry,
Thank you, sir.
got over my head.
Okay,
There are others that we do look at closely. Klebsiella resistant, carbapenem resistant, multi-drug resistant. Our numbers are very low. We haven't had to rely on, there are newer antibiotics, very expensive antibiotics. We have not had to use very much here because we do have good stewardship and can keep our numbers way down.
Okay.
I just want to comment, thank you and your team, your passion for trying to make JPS what it is today. No hospital is flawless, but you're getting a JPS there. It's amazing, your work, and you just keep on going for all these little hiccups and bumps in the road. You just go after it and put that puzzle piece back where it belongs and learn from the mistakes, and you just grow from it. And every time you come, it's just an amazing passion that it's just elevated, and I love hearing it and your passion for JPS.
I think as Mr. Early always says, we own it, we seek joy, and I still cannot say the last one. But here at JPS, I'm really very proud because we are centered in care and we are powered by pride. Thank you.
Well said.
The preceding was a paid political announcement.
Just, you know, I would agree that as you look at this, it's really impressive, really impressive. But somewhere along the line, I think that we also need to look at the intervention of this from a community side. And I'm raising the question, how could I, or how could JPS carry this outside of this room to help the community now practice intervention? How do we do that? To help them understand, you know, the terms, to help them understand things that they could do at home. And I was just sitting there just trying to dream in my head what could be done to do that, I think.
One of the things that we have actually been talking about, sir, is through the Strategic Operations Council, we have actually looked at how can we be more transparent in sharing the successes that we have as an organization, and also what are the things that we are working on so that we can learn from any failures. So we are currently working on making sure that we communicate those interventions. JR with our communications team is very influential in that area on how we can make sure that we can reach our population, our communities, and explain to them, you know, perhaps hand washing is very important, especially when you come to the hospital, so that we prevent infections. If we prevent infections, we prevent sepsis from happening. If we prevent sepsis, then we will have less mortalities. So definitely, sir, that is a great suggestion. We will work on it, and we hope to report on it in the coming months.
Yeah, I would hope that, I don't know what that is, but if we could develop some type of rolling team, some SWAT team, I think, that you know, that went to, maybe there's a community group that we could have it at the community health clinics on an evening where or churches or communities where these things could be talked about and explained. I think it would just help the community to, you know, as you educate the board here. There's no way in the world I could go out there and say this, but I think the experts could really help. Yeah.
I love it. I mean, and we have been pushing to get the TV screens all about that. And JPS.
No.
Oh, I'm like, take them down or do something about it. Because if you walk into any of the clinics and there is TV shows on, that's not what this hospital is about for me as a patient. I want to learn, I want to see, what is available to me and to others through those TV screens. When the TV screens were brought to the advisory council committee, that's what we thought they were for, is for them to teach the patients not to watch TV. And for me, it is one of those thorns in my side that I've been trying to get rid of them or do something about them for 2 years. And that's exactly where we should start. With the program that you are wanting to implement, it's right there. We have the tools, we have the IT people, make it happen.
Yes.
Yes, ma'am?
And I remember mentioning the last time we were together, about a little newsletter or, or just sending somebody out once in a while to the different clinics and seeing how many people you can gather up on a particular topic. And, draw your patients in so that they understand that this is your home and, gee, I can ask questions and, they're going to have a little seminar about hygiene, what, things that you can cook for your better health, how we can keep our infections, and just different whatever. I still think that, paper and talking is the best thing to get. We can get technology all day long, but still there are a bunch of us that this is what we relate to, somebody and reading it.
It's a marvelous message, and pardon me for balancing this, but I've already talked about Dr. Semmelweis and these guys who discovered that washing your hands was important, and they couldn't get doctors to accept it. So doing it and getting acceptance is two different things, but I salute your hopefulness of finding something to do with it. And I don't know, Jerry Springer or Wash Your Hands on the
Right.
TV, I get it.
Yeah, this irritates us, to have to go into the clinic and, you're watching television or talk shows, reality shows, and I usually just bring a book. You can't, need to, if you're gonna draw our patients in, let them say, oh my gosh, when I go into JPS, I know what it's gonna be about. It's gonna be all about health. Well, get ready, because that's what it's gonna be about.
Good thought. Ladies, thank you for your presentation. Yes, sir. Dorothy, I'm sorry.
I was wondering on my chart, I have to go back and look at it. Is there a little information deal when you pull up my chart that shows some of the facts and this information?
I don't know. I've not. Melinda,
Well, there's an information, where you could add something to it on that my chart that we could have some information.
Okay.
You just had your IT person come up here quickly and your CNO exit quickly. So we've
Something's going on
We've
here.
already transferred from one issue to the next.
I am so excited that you mentioned that, because there are two things we could do. We do have our after visit summary, and we're in the middle of doing a total review of our after visit summary, the ABS. So how can we put the right information on the front page that's critical for that patient related to their specific problems? But I think, there's one thing that is going on, and I think that's really important, and we need to remember that we want it on that first page. We want to reduce the number of pages so that they will read what we are giving them, and that we put the most critical stuff on that first page. But to your point, it was more informational.
Yeah.
When you go to look at my chart and you're looking at your individual stuff, as you open it, here
Right.
are the 5 critical things you might want to be aware of.
Right.
If you're going to visit the hospital, it is that showering beforehand, all the antibiotic things that we would like them to do prior to surgery.
And you can rotate it. You could have something that
Exactly.
is,
That's a great
because they
idea.
pull that up all the time. And I know they print stuff off, but I can just tell you for my family, I have to go through all the labs, so that I know it's the way you could get that there, so.
Absolutely.
Yeah.
So we'll follow up on that.
All right.
Thank you.
Yeah, I just think we'll use that.
Okay, pending other business, and before we convene an executive or dismiss and convene an executive session, I'd like to encourage everyone in the room to wash your hands, and we will move forward. Thank you.
You're so bad, all right.
We're in executive session, moving to it at 2:35 p.m. We're back in open session of the Quality Committee of JPS Tarrant County Hospital District. It's still the same day, September the 7th of 2017. The time is 3:10 p.m. The chairman of the next committee is anxiously waiting, and I would entertain a motion for adjournment. Dr. Weber, second by Mr. Powell. All in favor? We are adjourned.